Thank you for the question. So the SGLT2 inhibitors do have modest diuretic potential, and so it commonly comes up in clinical practice. What do you do when initiating an SGLT2 inhibitor amongst a patient who is already requiring a diuretic? In general, um, our current clinical practice or current clinical guidance suggests that you can start the therapy, have close follow-up, ask the patient to closely monitor their weights, congestive symptoms, and then closely reevaluate that. And in a patient who appears to have either improvement in clinical status or congestive status, they may be able to de-escalate an oral diuretic in follow-up. In general, for instance, in the pivotal DAPA-HF trial, there was actually very minimal background shifts in diuretics. So I don't think that at a population level, we're going to see a large reduction in use of diuretics, but in select patients, for sure, some patients may be able to lower their dose, or patients who are already on very low doses may be able to come off diuretics. So certainly no issues with background use of renin-angiotensin system inhibitors. In fact, for instance, our chronic kidney disease trials, which are arguably some of our higher risk populations, required or mandated background maximally tolerated doses of renin-angiotensin system inhibitors. So these were specifically studied in combination as an add-on therapy on maximally tolerated RAAS inhibition, and they're remarkably well tolerated. In terms of co-prescription, comes up sometimes with respect to heart failure and perhaps chronic kidney disease. Both classes of therapies are effective. Could we start them at the same setting? And I think in general, it's yes. We've had limited experience, and so I don't want to overgeneralize. Both do have important physiological effects on the glomerulus and intraglomerular pressures. So there is some concern that perhaps it could cause that early dip to be exaggerated. And perhaps some of the other side effects or adverse effects are overlapping between these two classes. For instance, they have some blood pressure lowering that may be additive or synergistic. They may have some effects on electrolytes, etc. But in general, I think they can be introduced very closely together and perhaps separated in terms of days or weeks to prevent any directly overlapping adverse effects.